Good morning, everyone, and thank you for that kind introduction. I'm incredibly honored to be here at the Swedish Neuroscience Institute giving grand rounds. And again, thank you for the invitation. This morning, I'd like to talk about optic neuritis, which again is my favorite topic. And it's my favorite because of the incredible breakthroughs we've had over the past decade in having biomarkers for NMO and MOG-associated disorder. And when we come across optic neuritis, it really just isn't multiple sclerosis anymore, and we really have to think about NMO and MOG because it actually it doesn't only change prognosis, it actually changes treatment. And so hopefully by the end of this talk, you'll be able to recognize the importance of differentiating MS, MOG, and NMO, and just hear about some of the new kind of breakthroughs we've been in terms of understanding these atypical cases of optic neuritis. I have no financial relationships. We are going to talk about some chronic immunotherapies for MOG-associated disease and ACOPOR4 NMO. And our present learning objectives are to review the differential diagnosis of optic neuritis. We're going to compare and contrast MS, NMO, and MOG, and we're going to talk about the treatments for these atypical optic neuritis cases. So as a background, I just want to talk about an overview of optic neuritis. I think we all know it's an inflammation of the optic nerve. It's typically caused by demyelination. And it's the most common cause of an acute optic neuropathy in young patients. Patients typically present with subacute monocular vision loss, with the nadir of vision loss typically happening about 3 to 7 days after the vision first starts dropping. And patients also often have pain with eye movements, a classic sign of optic neuritis. And patients will also complain of dyschromatopsia, where colors aren't quite as vibrant as they once were. And when we look at the optic nerve is actually typically normal because it's a retrobulbar optic neuritis. And when there's disc edema, it's typically on the mild end. And here's just a picture of that right here, just showing how if there is going to be disc edema, it's typically mild. And that's important to note because some of these other atypical cases of optic neuritis, you're not going to have that mild disc edema. And fortunately, the vision does tend to improve with optic neuritis over 1 to 3 months. I tend to tell my patients that 90% of patients get 90% of their vision back. But there are some patients that end up with a poor outcome. Here you can see that 3% end up with a vision of 2200 or worse, and 2200 is legally blind. So it's not always a benign disease. Much of what we know about the prognosis, the outcomes, and the treatment came from the landmark Optic Neuritis treatment trial, which was completed in 1991, published here in 1992 in the New England Journal of Medicine. And there they had over 450 patients, multi-center randomized trial comparing high-dose IV methylprednisolone, low-dose oral prednisone, and placebo, those 3 arms. And ultimately, what they found is that high-dose IV steroids quickens the recovery, but doesn't actually change the ultimate outcome. And surprisingly, they found that low-dose oral prednisone actually potentially increased the recurrence rate. And so at the time of the optic neuritis treatment trial, if you had a patient with optic neuritis, you had 2 options. One is to treat them with IV steroids to quicken the recovery, but not actually change the ultimate outcome, or to do nothing. And really, that's where we were. At the time of the optic neuritis treatment trial, really the main dichotomy is if you have a patient with optic neuritis, is it going to be MS or not? And so that was another main question that the ONTT tried to answer. And they did so excellently. Followed these patients for 15 years, and they found that the overall risk of MS after a bout of optic neuritis is 50% at 15 years. And what's nice is that's a real easy number to remember. And it's an important number to remember because, again, optic neuritis is the most common acute optic neuropathy in young patients. And no matter what field of neurology you practice, you're going to either see a patient or know someone who's got optic neuritis. And the first thing on their mind when they have it is, well, what are my chances of MS? And you can tell them it's 50%. The trial also further stratified the risk based on the presence or absence of white matter lesions. And so if there's no white matter lesions, there's a 25% chance. And if there are white matter lesions, 72% chance at 15 years. And here are just some examples of some periventricular white matter lesions coming off the lateral ventricles. And you can see why these are called Dawson's fingers, because they look like fingers coming across over the ventricles. And so we all have sort of a gestalt or an idea for your typical MS patient with optic neuritis. Classically, it's going to be a young adult female. Caucasians are more affected. The vision is typically mild to moderate vision loss, but it can be severe at times. Classically, patients have good recovery. Disc edema is typically mild if it's present and only present in a third of cases. And of course, you've got the classic periventricular white matter lesions. So I want you to just keep this patient in mind as we compare and contrast it to some of these other demodeling disorders that can cause optic neuritis later. So again, let's go back to the dichotomy MS versus not MS. And within not MS, we've got idiopathic, which is a large group, and we've got infectious and inflammatory etiologies. And for the inflammatory etiologies, we've got sarcoid, lupus, granulomatosis with polyangiitis. These are inflammatory vasculitic processes that can affect any part of the eye, any part of the brain, and they can cause optic neuritis. We're also going to talk about some of these infections as well. So obviously, take a look at this external external picture. You know what this is going to be. This is going to be herpes zoster ophthalmicus. But zoster really can affect any part of the eye. It can affect the cornea and cause a keratitis. It can cause uveitis, a retinitis. It can affect some of the cranial nerves and cause double vision. And it can cause inflammation of the optic nerve and cause an optic neuritis. And again, it can affect any part of the eye. And so any patient with a zoster rash in the V1 distribution really needs an eye exam because it really changes our management in terms of how we can treat the ocular manifestations. And of course, it can affect any part of the brain as well. As a patient with Lyme, retinal choroiditis, and papillitis. And if you look at the fundus photo, you know that this isn't going to be your typical patient with MS because there's too much disc edema, there's peripapillary hemorrhages. And if you look closely at the retina, you can see these deep yellowish lesions, and these are retinal choroiditis lesions. Really leans you more toward an infectious and inflammatory etiology. And again, Lyme can affect any part of the eye, most commonly uveitis and chororetinitis, but it can also cause an isolated optic neuritis, very rarely. So if you live in an endemic area, at least it could be on your differential. This next patient, I just wanted to present it as a mystery, at least early on. So this was a 62-year-old male who presented to the Neuropathy clinic because of complaints of decreased vision in the left eye. Further history revealed that he had some chills and night sweats and then fine erythematous rash. What's interesting is that the left eye is the one he was complaining about, but you can see the right eye actually was very swollen with these peripapillary hemorrhages, and yet the vision was 20/25. The left eye just had a trace amount of disc edema, but that eye was 20/70. So we've got to try and explain, well, why is he not seeing on that left eye? So we got optical coherence tomography, or OCT, which allows us to look at all the layers of the retina. And these are some cross-sections through the macula. In the right eye, the retina is completely normal. And so I want to draw your attention to this line down at the bottom, this white line there. That's called the ellipsoid zone. And those are actually the photoreceptors of the patient. And if you compare the right and left eye, you can see in the left eye, that white line is actually gone, and you can see these clumps right there, and so those are the photoreceptors that are clumping up. And if you look at the fundus photo, you can actually see this kind of yellowish hue there in the macula, and that's a placoid choroidinous lesion, and that's actually pathognomonic for a certain infection. Any takers on the infection that could be causing this? This is syphilis, exactly. So this patient was positive for RPR, TPPA, and VDRL, and this was syphilis. And syphilis can affect any part of the eye, any part of the brain. And it's important to recognize because if you make that diagnosis and you treat them with penicillin, they will improve. This is just 14 days after initial presentation with the IV penicillin, and you can see that the disc edema is significantly better in the right eye. The left eye is now 20/25, complete restoration of the photoreceptor layer compared to the baseline. But if you catch it late, some of these changes can be permanent. And so it's important to know. And another reason it's important to know is the syphilis rates really have been going up since 2000. So here we had the lowest drop in 2000, but since then it's been going up every single year consistently. And in every state, it's been going up. And here we are in Seattle. We're about 50% of the country here. Here I am in Minnesota. We've got a twofold increase here in Washington. So just have to think about syphilis. It can affect any part of the eye, any part of the brain. Okay, going back to our chart in terms of how we approach optic neuritis, pretty much for about 15 years after the optic neuritis treatment trial, there was a lot of debate on where to put NMO in all this. Was it a subtype of MS or was it separate? We've actually known about neuromyelitis optica since 1894 when Devick and Galt first initially presented their series. That's why sometimes this is called Devick syndrome. Patients classically present with severe relapsing optic neuritis and a very long segment of transverse myelitis. And this is a patient with an optic neuritis in the right eye in the past, and you can see the nerve is very pale. She never recovered, and she has count fingers vision in that eye. And then, unfortunately, has an optic neuritis in the left eye with a hyperemic nerve, and now she's 2400. So, unfortunately, is going to be legally blind in both eyes. And on the imaging of the spinal cord, you can see this inflammation in the spinal cord that actually extends 5 segments. And that's really classic for neuromyelitis optica, because for multiple sclerosis myelitis, they tend to be very short segments. And so it really does seem to be slightly different. But the question was, well, is it just a more severe variant or not? And so this was actually published in 2007, so 15 years after the optic neuritis treatment trial, and we're still trying to debate, is NMO a distinct entity or not? And there are experts on both sides of the field, really world-renowned experts saying, yes, it's a variant of MS, and others saying, no, it's separate. And so really at this point, people were just saying, well, we're not sure, either you're a lumper or a splitter. There's a coin toss. But really, ultimately, the answer came from the lab that's a separate entity. And that was Lennon and colleagues at the Mayo Clinic in 2004 actually found the NMO antibody against aquaporin 4, which was found to be both a marker and a pathogenic cause of NMO. And it firmly cemented NMO as a distinct entity from MS because we actually have a marker for it. So aquaporin 4 is our water channel proteins found in the astroglial foot processes and expressed in the brain, the spinal cord, and the optic nerve, which is why these are the areas that get affected so commonly in NMO. And when the aquaporin 4 antibody binds to aquaporin 4, it actually activates complement, astrocytic injury, and then secondary demyelination. So it actually has a different pathway than multiple sclerosis. The aquaporin 4 antibody has a sensitivity of 76% and a specificity of 99.8% for NMO. So it's an incredibly specific antibody. And the serum is actually more sensitive than the CSF for the NMO antibody. So in 2006, Wengerchik and colleagues had a diagnostic criteria that was actually pretty easy to remember. We've had optic neuritis, transverse myelitis, which we've known are the 2 most common symptoms for a century. And they had at least 2 of the following: a long transverse myelitis, an MRI without periventricular white matter lesions, and a positive antibody. So pretty easy to remember in 2006. But now that you have a biomarker, a specific biomarker for disease, the disease spectrum is going to grow because there's demyelinating conditions that we didn't think were NMO that could be. And so that led to the new international criteria that was published in 2015. And you can see it's a lot more complicated now. But I just wanted to boil through the main clinical core characteristics. So the 2 most common are still optic neuritis and transverse myelitis. The 3rd most common is something called areoposterior syndrome, which many of you may have seen. But here you actually get inflammation, demyelination in the areoposterior within the medulla, and patients present with refractory hiccups or vomiting. It's actually even hitting the lay press now. So this was published in the New York Times Magazine just a few months ago, and the title was, "She had terrible heartburn and vomiting, but her problem was not in her stomach." So this is a 43-year-old female who had intractable nausea and vomiting for 4 months, had a huge GI workup, ultimately never found the cause, and then it just spontaneously went away. But then a year later, she again developed nausea, vomiting, hiccups, but also had double vision. That led to the MRI, and this patient had NMO. And so this really can be the presenting sign of NMO, and obviously as neurologists, we need to know about it, but even ER and GI physicians need to know about this as well. NMO, the other core clinical characteristics are acute brainstem syndrome, symptomatic narcolepsy, and symptomatic cerebral syndrome. And you can make the diagnosis with 1 core clinical characteristic and a positive antibody. And you can actually make a diagnosis of seronegative NMO if you have 2 of the core clinical characteristics, and one of them have to be one of these top 3. In terms of the epidemiology, it really depends on which area of the world that studies it. It's a prevalence of 0.5 to 10 per 100,000. And the variability is because it only accounts for 1 to 3% in Caucasians in terms of demyelin disease, but 20 to 48% in Asians. Dr. Flanagan at the Mayo Clinic looked at the incidence in Rochester, where we're predominantly Caucasian, and compared to our colleagues in Martinique, which is 90% Afro-American. And you can see that it's 0.7 per 1 million in Rochester, but tenfold higher in this predominantly Black population. It's 3 to 7 times more common in women, so that's even more female predominant than you see in multiple sclerosis. And the median age is 39, so about a decade after MS. So again, comparing MS to aquaporin 4, for NMO, we're gonna have middle-aged adult female, Black and Asians more commonly affected than Caucasians. The reason why we see this and why it's important in our ophthalmology is the severe vision loss with optic neuritis from NMO. The vision loss is very severe at onset and unfortunately has poor recovery. 50% of patients will end up with a vision of 2200 or worse, which is legally blind, compared to about 3% for MS, so just a lot worse outcomes. Things that make us think about optic neuritis from aquaporin 4 is the severity, but also oftentimes the lesions are more posterior, so if you see a chiasm lesion, you want to think about NMO, not MS. And of course, if you see long transverse myelitis, area postrema syndrome, those are all tip-offs for NMO. And other parts of the brain can be affected as well, including the diencephalon, your respiratory centers. Patients can end up quadriplegic. And mortality rates have been reported to be as high as 32%. Fortunately, now we're much closer to 6%, perhaps probably even better than that now that we've got earlier diagnosis, better treatments. But this can be a fatal disease. Yes, of course.
So earlier you were saying that 90% of people with just idiopathic optic neuritis have good recovery. Do you tell them that before you do an MRI and serum them, or do you wait until after those studies before you give them that?
Right. I still tell them that the majority of patients are going to recover. Obviously, if they're coming with no light perception, really bad vision, chances are they're still going to recover. But obviously, if they come in with severe optic neuritis, we tell them that there's a chance they won't recover. But we do tell them, we try to paint an optimistic picture, and yet with enough caution that they may not recover.
Do you tell them about the NMO?
We tell them that we're going to be checking for it. The drawback is it takes 1 to 2 weeks to get the answer. But we're going to talk about treatment in a little bit and how we might be able to curb the outcomes a little bit better than the natural history. Because the NMO attacks are so severe, we typically treat them with IV corticosteroids, just like we normally would, but a very, very low threshold to add on plasma exchange. Typically within 5 days, if they're not responding to the IV steroids and they've got severe vision loss, we're adding on plasma exchange. And in Europe, plasma exchange is often just first-line therapy. They're just going right to plasma exchange. Of course.
If you see someone with optic neuritis, get the MRI, it looks kind of like MS, and you haven't yet had a chance to do the spine MRI, right? They don't have any spine symptoms, and anything with transverse myelitis. They don't have any other symptoms. Would you go ahead and order the NMO antibody, or would you wait till you get your spine MRI?
Well, typically for the spine MR, if they don't have any signs of transverse myelitis, there's not going to be a longitudinally extensive lesion hiding in there. Because
so it's not even worth going down that pathway?
You can to help stratify the risk of MS, which would make it less likely to be aquaporin 4, but you're not going to be hunting for that transverse myelitis. But we'll talk about when we test. But I think you could argue you could test for aquaporin 4 for any patient with optic neuritis, unless it's just classic MS with mild vision loss, because it really does change management, which we're going to talk about.
And how often do patients with optic neuritis not have a lesion in the cord in an MO? It must be fairly common.
It's very common, absolutely, absolutely. So how often do patients not have a lesion in the cord? It's 50% of the time it'll be optic neuritis, 50% of the time it'll be transverse myelitis. So yes, a lot of times it's only going to be optic nerve. And so yes, if it's an optic neuritis, we're pretty much checking aquaporin 4 for almost all of them, unless it's just classic MS with prominent periventricular white matter lesions, small lesions on the cord, positive gluconal bands. But because if we do detect aquaporin 4, it's such a specific biomarker, and it changes our management, it changes the acute management, and more importantly, it changes the long-term management. So all patients, because of the fact that they tend to relapse, the recoveries are poor, they all need to be on long-term immunotherapy. Rituximab is our classic first go-to. Isothioprin, mycophenolate, or some other options. But if you're going to take away one thing from this talk is that MS medications don't work for NMO. So if you incorrectly diagnose a patient with MS, but they've got NMO, these MS medications may actually even increase the relapse rate of NMO. And I mentioned this mortality rate. So essentially we can't incorrectly diagnose patients anymore now that we've got a specific biomarker. It's been a really exciting year. This past year of 2019 was actually called the Year of NMO by the American Academy of Neurology, because there were 3 different separate trials that all showed excellent efficacy in preventing relapse compared to placebo. So the first was the PREVENT study, and this was looking at eculizumab, a complement inhibitor. And this was an exciting medication because it actually took the pathway for how aquaporin 4 works. We know it binds to aquaporin 4, activates complement, and then secondary demyelination. So the eculizumab is a complement inhibitor, knowing that's how aquaporin 4 works. And it led to a 94% reduction in relapses compared to placebo and became the first FDA-approved medication for NMO. We also have the NMO Momentum study that looked at enobalizumab, which is a CD19 inhibitor, and also showed a significant reduction in relapses compared to placebo. And most recently was the Sakura STAR study, which looked at satralizumab, an IL-6 inhibitor, also showed to be much better than placebo. So we had 3 randomized multi-center clinical trials, placebo-controlled, all in 2019, all successful. So 3 for 3, getting published in New England Journal of Medicine and Lancet. So it's really an exciting time to be a neurologist, neuroophthalmologist, and neuroimmunologist, because we are really expanding our repertoire in terms of being able to treat this condition. So I think going back to the schematic, we know now that NMO is a separate entity from MS. But what's interesting is only 75% are positive for that specific antibody, which means there must be some other biomarkers that we weren't aware of. And one of them, the more recent one, is actually antibodies against MOG. And this was being kind of recognized for the past 3 years or 4 years, so pretty new. And this explains about a third of these seronegative NMO. And it also explains some cases of very atypical MS and cases of recurrent optic neuritis. And so antibodies against MOG are much newer, so some of you may not be that familiar with it. So I thought I'd start just with a classic case of MOG optic neuritis. This patient actually presented to the ED. This was actually about 3 years ago, just when we started having MOG on our radar. And presented to the ER with blurred vision and pain in both eyes. And my resident, one of our ophthalmology residents, saw this patient. And he said, "Dr. Chen, this patient has bilateral papilledema. I'm worried about raised intracranial pressure. Let's get an MRI, MRV, and a spinal tap." What's interesting is this patient was count fingers in both eyes. And I would argue that, yes, papilledema causes vision loss, but usually if you see a fulminant case of papilledema, it's grade 5 papilledema if you're going to have count fingers vision loss. And this is severe, but it's probably more of a grade 3. So really, I wasn't suspicious of raised pressure here. I was suspicious of an optic neuritis. So we get an MRI of the orbits, and you can see enhancement of both optic nerves. And what's interesting is the enhancement actually isn't just within the optic nerve itself. It spills into the optic nerve sheath and the peribulbar fat. And that's called perineural enhancement. And that's actually a very pathognomonic sign for MOG. So looking at a differential diagnosis of optic neuritis, the 2 other demyelinating conditions, I could say we could actually scratch them off the list based on the disc appearance and the way the optic nerve enhancement is. They don't tend to have this pattern. So then we've got MOG-associated disorder. Yes, it could be sarcoid, infection, idiopathic, but it's not going to be MS or aquaporin 4 NMO. So at the time, this patient was diagnosed with an atypical optic neuritis. It was atypical because it was bilateral. There was a lot of disc edema. We just don't see that in our classic MS optic neuritis. There were no oligoclonal bands. The aquaporin 4 antibody was negative, and the infectious and inflammatory workup was negative. This patient was treated with IV Solumedrol, and within a couple days, the vision was back to 20/20 from count fingers. And that's also something very atypical, because with MS optic neuritis, we know that if we treat with IV steroids, we quicken the recovery from 5 weeks to 2 to 3 weeks. But this is oftentimes like within a day, they're back to 20/20. And so they're very steroid responsive. But sometimes with MOG optic neuritis, when you come off the steroids, they relapse. So they're not only steroid responsive, they're steroid dependent. And so every time we treated this patient with steroids, the vision came back, came off the steroids, the patient recurred. And so they were diagnosed with chronic relapsing inflammatory optic neuropathy, which is essentially a steroid responsive but steroid dependent optic neuritis. And we actually stabilized him on azathioprine. But ultimately, when we had the antibody, the patient was MOG positive. So it's not idiopathic cryon, this was MOG-associated optic neuritis all along. So what is MOG? MOG stands for myelin oligodendrocyte glycoprotein, which is a transmembrane protein found on the surface of oligodendrocytes in myelin. And antibodies to MOG have been speculated to be involved in demyelinating disease for actually decades now, because one of the most common animal models we have for demyelinating disease is actually MOG antibodies to cause experimental autoimmune encephalomyelitis. So for decades, we've been thinking that this is probably involved in demyelination, but we didn't know how. And in the early 2000s, it was actually incorrectly thought that it was a marker of MS. This was published in the New England Journal of Medicine, but these results weren't replicated. And the reason why is at the time they were using less reliable antibody assays. They're using Western blot and ELISA. But to actually correctly identify the MOG antibodies, you actually have to look for MOG in its conformational form using a cell-based assay, which is shown here. So at least how we do it at Mayo is we take HEC293 cells, which are human kidney cell lines, and we transfect them with MOG. So then the MOG actually gets expressed on the surface of these cells in its conformational form. And that's what allows for the specificity of finding this antibody. We then take the cells and expose them to human serum that do or do not have the antibodies. But if they do have the antibodies, they're going to bind to that MOG that's being transfected by the cell. And we detect that binding with an IgG1 specific secondary and flow cytometry. So the MOG FACS cell-based assay first became commercially available at the Mayo Clinic in 2017, October of 2017. And that was actually the first commercially available MOG assay in the US. So we've only had this assay available commercially for 2 years now. So that's why this disease spectrum is constantly growing. Over the past year, both Quest and Arup are also some other labs that are offering MOG testing as well. So it's much more easily accessible. But really, we've had this antibody, again, only for 2 years. So the spectrum is going to expand, just like NMO expanded. I'm sure this will expand as well. But in terms of what we know about it right now, is that MOG-associated disorder is distinct from MS. It can affect any age with a median age of 33. It makes up over 20% of demyelinating attacks in children, and probably about 5% of demyelinating attacks in adults. And if you think about childhood optic neuritis, before we had MOG antibody, we knew that childhood optic neuritis tended to be bilateral, tend to have severe onset, good response to steroids, and often were steroid dependent. These are all classic features of MOG optic neuritis. So we've always had a gestalt idea of childhood optic neuritis, and it's because a lot of those were MOG. Interestingly, the male to female ratio is about 1-to-1, unlike MS and NMO. And it's probably about 2 times as common as aquaporin 4 optic neuritis. So I just wanted to talk about different ways MOG can present. Optic neuritis is the most common way it presents, which is why we see it as neuroophthalmologists. 50% of the time it's isolated. 50% of the time there's other features as well. And it probably explains about 25% of what was previously idiopathic, steroid responsive but dependent optic neuropathy. And in terms of features that make you think about MOG optic neuritis, one is 50% are bilateral, 50% are recurrent, some are steroid dependent. So if you have any of those features, you want to think about MOG. Another striking feature is the disc edema, which is present in up to 86% of patients. And it can be severe, sometimes even with peripapillary hemorrhages. So that's why sometimes these patients are confused as having papilledema or ischemic optic neuropathy. It doesn't have to be severe, but if it's present, you're not going to typically see that with NMO or MS. You want to think about MOG. There's some radiologic clues as well, and we touched briefly on that. One is the enhancement of the optic nerve sheath, and especially if it extends into the peribulbar fat, which we call perineural enhancement. That's very pathognomonic for MOG. And bilateral lesions and long lesions extending more than 50% of the nerve are also very suggestive of either MOG or aquaporin 4. You're not going to typically have this kind of radiologic feature in MS. But this is probably the most specific feature just for MOG itself. The good part about MOG is the outcomes are typically much better. They present very severely. Count fingers vision is the average onset in terms of the vision loss, but patients tend to recover much better than aquaporin 4, which leads to better visual outcomes. This was a study looking at recurrent optic neuritis and comparing the outcomes between aquaporin 4, MS, and MOG. And this blue line here is aquaporin 4, and this on the y-axis is the chance of retaining good vision. And this on the x-axis, we've got time. And you can see here with aquaporin 4 NMO, as they get more recurrent bouts of optic neuritis, the chance of retaining good vision is pretty poor. Whereas here in pink is MOG. Despite recurrent bouts of optic neuritis, patients tend to retain good vision. And overall, most studies show that about 6 to 10% of patients with MOG will end up with that poor outcome of 2200 worse, compared to 50% for aquaporin 4. So even though the onset, the attacks are severe, recurrence is common, outcomes are much better. So it can also cause transverse myelitis. And so here's just an example of that. And this is a transverse myelitis extending 4 segments. So it's a longitudinally extensive transverse myelitis. But one feature that can help tip you off toward MOG is if you look at the axial cuts of the MRI, you'll see that oftentimes the inflammation is restricted to the central gray, which we call the H sign. And if you're a sports fan, you could say, well, maybe that's the Under Armour sign. And then if you're a Stars fan, it's a TIE Fighter sign. But regardless of what you call it, if you see that central gray that's being affected, you want to think about that this is probably MOG, not aquaporin 4. And of course, if you've got an optic neuritis, you've got a long transverse myelitis, that meets the 2015 diagnostic criteria for NMO. Of course, in 2015, we didn't know about MOG, and so the next diagnostic criteria will clearly have MOG as a separate entity, but right now it still meets that diagnostic criteria, even though prognosis is so different. It actually explains about a third of cases of seronegative NMO. The other main phenotype that patients can present with is acute disseminating encephalomyelitis, or ADEM, where patients can have significant inflammation in the brain. It predominantly affects children, but it can affect adults as well. And this can be actually a pretty scary finding because, patients can have encephalopathy, confusion. I remember when I first started at Mayo about 5.5 years ago, we had several patients who came in, they were bilaterally blind, diffuse brain inflammation everywhere. They really kept me up at night because, we didn't know, is this inflammation, infection, neoplastic? And a lot of these patients we just empirically treat with steroids and they miraculously got better. In retrospect, all those patients were MOG. I would have slept much better if I had that assay back then. But a lot of these patients actually end up with brain biopsies to try and figure out what was going on. But now, obviously, we've got a much better biomarker that we don't need to anymore. And it's not multiple sclerosis. So these are the diagnostic criteria that our group published in the JAMA Neurology, and it really hinges on that positive MOG assay in the serum by cell-based assay, which is more sensitive, more specific. And then those core clinical characteristics of ADEM, optic neuritis, transverse myelitis, or some kind of other demyelinating disease. And of course, you want to exclude alternative diagnoses like multiple sclerosis, aquaporin 4. Again, it's distinct from MS. It's very rare for classic MS to be positive for MOG. And treatments with MS medications are ineffective for MOG-associated disorder. I think you can take away from this talk that it's distinct from aquaporin 4 NMO as well. There's almost no patients that are positive for MOG and aquaporin 4, and we're actually going to talk about some studies looking into detail for that. And then, of course, we kind of accidentally have pathology from some of these patients before we had good biomarkers. But if you look at the pathology in aquaporin 4 NMO, you actually see astrocytic destruction and secondary demyelination. But in the MOG pathology, you see pattern 2 demyelination. And so even on pathology, they're different. And of course, the outcomes for MOG are better. And it's got a different prognosis and a different treatment. So let's talk about treatment. So for acute attacks, we typically treat them with IV methylprednisolone for 3 to 5 days. And the one difference we do from MS is we tend to do a little bit of a longer oral prednisone taper over 1 to 2 months because some of these patients are steroid dependent. And when you come off the steroids too quick, they can relapse. Unlike aquaporin 4, where we're doing plasma exchange on any severe optic neuritis, for MOG, we tend to use it much less. We only use it if there's severe vision loss and no recovery at 1 to 2 weeks do we consider plasma exchange. And in children, we'll use IVIG more commonly. So again, very different from aquaporin 4, where we're doing plasma exchange very early on because the outcomes are typically much better. The other big difference from aquaporin 4, we talked about with aquaporin 4, every patient needs to be on chronic immunotherapy. For MOG, if they've got a single attack complete recovery, we're not putting any of them on chronic immunotherapy because only 50% are going to relapse. And even if they do relapse, the outcomes are typically good. And so typically we reserve long-term immunotherapy for relapsing disease. So again, another difference from aquaporin 4. So if you are going to need to put them on, let's say they do have relapsing disease, what is the medication you're going to use? This was a study by Hakon et al. That was published in 2018. And here you can see that on the left, they've got their annualized relapse rate before treatment, and this is annualized relapse rate during treatment for MS medications. And you can see everything is pretty much a horizontal line. So MS disease-modifying agents don't work for MOG-associated disorder. When they looked at some of the medications that we commonly use for NMO, like rituximab, mycophenolate, azathioprine, you can see that there is a trend toward decreasing attacks for all the treatments, not down to 0, but a decrease in all of them. And you can see here, interestingly, IVIG had a nice trend down as well. So we actually did a multi-center retrospective study looking at 69 patients with MOG treated with long-term immunotherapy. And I just want to highlight a couple of things here. This a little bit off here. So we've got our MS medications. You can see that pre-treatment was 1.8, post-treatment 1.5, so no difference. But one thing here is that it's not going up. It's not actually worsening disease, it's just not helping. Whereas aquaporin 4 disease, it could potentially worsen things. Your classic medications for NMO, they all cause a reduction in the annualized relapse rate, but not to 0. And then the last one I wanted to highlight, let's see if I can make the red boxes go away. There we go, is IVIG. We only had 10 patients, but you can see here the pre-treatment annualized relapse rate was 2.8, and only 1 patient relapsed on IVIG every 3 to 4 weeks. So that may be a very efficacious medication for MOG-associated disorder. Obviously, larger studies, randomized trials may be required, but it does factor in terms of how we approach these patients. So if a patient does need chronic immunotherapy, our first line is typically rituximab or azathioprine, often with a low dose of oral prednisone. Prednisone itself works incredibly well. If they're on 60 milligrams of prednisone, they're not going to relapse, but patients can't be on 60 milligrams forever, so if we can't get them low enough, we'll have to add on some of these other medications. Rituximab is an interesting one because, again, that's your go-to medication for aquaporin 4, but for MOG-associated disorder, it causes a reduction in relapses, but probably not quite as effectively as it does for aquaporin 4. And if a patient has severe relapsing disease, that's when we'll switch over to IVIG every 3 to 4 weeks if they break through some of these other medications. I guess one question people will wonder, well, will I ever see aquaporin 4 or MOG in my clinic? And the question is, well, how common is it? And that's something that we wanted to look at. So A lot of studies on the incidence of diseases comes from the Olmsted County because there's a resource called the Rochester Epidemiology Project where we can actually get population-based incidences on various diseases. And so back in 1985, they found that the incidence of optic neuritis was 5.1 per 100,000. 52% were MS and the 48% were idiopathic or something else. But of course, this was done before the knowledge of aquaporin 4 and MOG. So we redid the study looking between 2000 and 2016 to see, well, what are the causes now? 57% were MS, 31% were idiopathic. So that idiopathic group is going down. And that's because 3% were aquaporin 4 and 5% were MOG, which means that 8% of optic neuritis just in a normal population will be MOG or aquaporin 4. So if you see enough optic neuritis, you're going to see some cases of this, and MOG is probably 2 times as common as aquaporin 4. So now that we have these biomarkers, we approach optic neuritis a little bit differently. And so this was a recent review we did in the Survey of Ophthalmology, looking at how we approach optic neuritis. And we kind of touched on some of this already. But the workup is slightly different. So back at the time of the ONTT, essentially, if you have optic neuritis is a clinical diagnosis, if you have a bout of optic neuritis, you're going to want to get an MRI brain to determine the risk of MS. But we'd argue now that we've got radiologic features that could suggest MOG or suggest aquaporin 4, we would recommend getting an MRI and of the brain and orbits, because if you see this perineural enhancement, that's not going to be MS, that's going to be MOG. If you see chiasmal involvement, that's probably going to be aquaporin 4. So again, for the workup, MRI brain and orbit. For also part of the workup.
Can I just interrupt?
Yes.
And both of those are less likely to have sort of the conventional periventricular.
Absolutely. Much less likely to have the conventional periventricular white matter lesions. Yeah, that's not 100% zero, especially because there's a lot of times we'll get this non-specific white matter lesions that patients have with migraines, microvascular disease, but they won't typically have those classic ovoid periventricular white matter lesions. But a lot of us just have these non-specific changes, and it kind of muddies the water a little bit. Next, just when do we test for these antibodies? And I think that's important. We touched a little bit on this already. Again, I think you can consider testing for any patient unless classic MS, especially aquaporin 4, because that just completely changes management, both acute and long-term therapy. And I think we could argue it probably is required now for any atypical optic neuritis. So that's severe vision loss, bilateral recurrent optic neuritis, prominent disc edema, long segment enhancement, perineural enhancement or chiasmal involvement. So just some of these features here. If you see any of those, I think we have to test for that. And of course, any lesions outside the optic nerve that aren't classic for MS, like Edema, a long transverse myelitis, area post-treatment syndrome, we're going to want to check for these antibodies. And then how do we test for it? Well, you actually want to test the serum, not the CSF. It's thought that the antibodies actually get created in the serum, and then there's a breakdown in the blood-brain barrier, and then they get access to the CSF. So you're going to actually test the serum. And you want it to be a cell-based assay, because that's when you're testing those antibodies in their conformational form. It's going to be much more sensitive and specific than ELISA and some of the other tests they have available. Another question is, well, can MOG and aquaporin 4 ever be jointly positive, dual positive? And so we just recently looked at this. We reviewed 15,000 patients tested for both aquaporin 4 and MOG. We found that 10 had dual positivity, so 0.06%, so pretty rare. And if you only look at patients that are positive for either MOG or aquaporin 4, it's still only 0.6%. So again, pretty rare. And if they do have dual positivity, they're going to follow an aquaporin 4 pattern. So severe demyelination, poor recovery. And typically the titers for the aquaporin 4 are much higher. And then the MOG titers are usually low when they're dual positive at like 1 to 20 or 1 to 40. So we think that it's just, for this, it's patients, these are truly aquaporin 4 patients. And these patients have a tendency toward autoimmunity. That's why they end up sometimes with MOG antibodies. That's why they end up with a higher chance of having lupus. It's just that autoimmunity that these patients have. But if you've got dual positivity, it's really driven by aquaporin 4. Another big question is, does persistent MOG titers matter? This was a study that we looked at patients with Edema, and you can see here if you've got transient MOG, you're less likely to relapse than if you've got persistent MOG. Both in adults and children, there was a higher rate of relapse. And there's been several studies supporting this, and some studies suggesting that the correlation is a little bit weaker. I think bottom line is that if you're transiently positive, which is about 25% of the time, there truly is a decreased risk of relapse. If you're persistently positive, it doesn't guarantee you're going to have a relapse. In fact, we've had some patients where I'm still looking back at old charts, and I'll see a patient from 15 years ago that had an optic neuritis that really looked like MOG. So I'll call them up, get their blood, and lo and behold, they're actually positive for MOG. But they only had a single attack 15 years ago, which means they were seropositive for 15 years without a relapse. So bottom line is, persistently positive titers doesn't guarantee a relapse, but if you truly become seronegative, probably less likely of relapse. All right, treatment is the next. One thing that I want to talk about, and we touched on this a little bit, is, of course, we can consider IV steroids to quicken recovery in anyone. But if a patient has severe vision loss, which goes to your question here, what do we do? And we actually recommend treatment for any severe optic neuritis because we're not going to know the antibodies for 1 to 2 weeks. It just takes that long to come back. So any patient who presents with 2200 vision or worse, we're treating with IV steroids even before we have serologic confirmation because we don't know who's going to have aquaporin 4. This was a study that was recently published by Stibo, Kalish, and others, and they retrospectively looked at patients with aquaporin 4 and MOG optic neuritis, and they found that better recovery was seen with earlier treatment within 7 days. And so if you've got a patient who comes in with light perception vision and you're waiting for those antibodies to come back, you're going to miss that window of 7 days where they found that recovery is better. So again, any patient with severe optic neuritis, we just recommend IV steroids early on. So it's a little bit of a change from the optic neuritis treatment trial. And then we talked about if you know they're aquaporin 4 positive, low threshold for plasma exchange. Almost all of them get it if it's severe. And for MOG, we very rarely use plasma exchange or IVIG, just unless they have poor recovery, severe vision loss, do we consider adding that on. And then lastly, chronic treatment. We know MS medications for MS. Aquaporin 4, all patients need immunotherapy. And we've got some new exciting medications down the pipeline. And then for MOG, really, you're only going to be using it for recurrent demyelinating disease. So just in summary, just going to compare and contrast these. We've talked about aquaporin 4 and MS, and so for MOG, it's going to be any age and sex, plus children, any race. The vision loss is just as severe as aquaporin 4 at onset, but the recovery is so much better, which leads to that better outcome. You want to think about MOG optic neuritis when there's lots of disc edema, when it's bilateral, when you see this perineural enhancement. Both MOG and aquaporin 4 can cause a long transverse myelitis, but with MOG, it's often that central gray causing that H sign. And then in terms of lesions outside the spinal cord and nerve, you think Edema, think MOG, area postrema, think NMO, and of course, periventricular white matter lesions, you're going to be thinking MS. So this is kind of that convoluted way we got from MS to aquaporin 4 to MOG, but really, they're all separate entities. So if you have a patient with optic neuritis, it might be aquaporin 4, it might be MS, but really they're all separate entities. And unfortunately, 31% of our optic neuritis is still idiopathic, so there's still going to be some unknown markers and antibodies that we don't know yet that we need to discover. And I'm sure there's going to be some atypical cases of MS that we're going to pull from that umbrella into these unknown antibodies. And so it's important to have these biomarkers because, of course, it not only influences prognosis, but ultimately when we understand the mechanism of the disease, it can influence treatment. And so constantly striving to understand these antibodies and understand these disorders better. So in summary, optic neuritis has multiple causes, MS, aquaporin 4, and MOG. I think these biomarkers have to be tested for any atypical optic neuritis and really could consider testing them for any patient unless it's classic MS. MOG is associated with recurrent optic neuritis, bilateral involvement, disc edema, and that perineural enhancement on the MRI of the optic nerves. It's distinct from MS, and fortunately better outcomes than NMO. I just wanted to thank all the collaborators we have at the Mayo Clinic, especially Owen Flanagan, Tariq Bhatti, Sean Pittock are really instrumental in a lot of this work. And we've got phenomenal neuroophthalmologists in the US that have collaborated and contributed patients to this growing understanding of optic neuritis. And I just want to thank all of you for your attention and the invitation to speak here. Yes.
Any data on spinal fluid? I mean, we don't do that much anymore, but do you have any information on MOG and
That's really interesting. So spinal cord, or spinal fluid, you mean? So for aquaporin 4, we did a pretty large study on that, looking at the sensitivity, specificity of the CSF for aquaporin 4. And essentially what we found is that it will sometimes be positive, but the titer is always lower. So if you had a patient with aquaporin 4 positivity in the serum of 1 to 10,000, then maybe the CSF might be positive at 1 to 100. So it seemed like it was just a spillover effect, but it just wasn't as sensitive or specific. The MOG was actually, it's interesting. There was a paper that just came out in Neurology, actually, where they took some patients that looked like MOG disease, but were seronegative on the serum, and they actually found a few more that were positive in the CS that were negative in the serum. The verdict on that is still out. We personally didn't find the CSF very sensitive or specific, but we're redoing our analyses and redoing our assays to try and answer that question. Maybe MOG is a little different there.
But what are their proteins, or do they have oligo?
Oh, gotcha. That's a good question. Yes. Yeah, so it's probably OCBs, MS, we think 90%. For these, it's probably about 5 to 10%, depending on the study you look at. So it can be positive, but much less likely. Protein and pleocytosis, they actually, during an acute attack, especially if it's ADEM or some of these more large inflammatory ones, you can have more pleocytosis and elevated protein compared to MS. Typically, if it's just optic neuritis, you won't. All right, Steve.
Quick question. So what I conclude is we should be testing sooner, especially patients who present with severe or bilateral visual loss, because the treatment decisions, especially like Flex, if you're waiting for the assay, right now it's taking 2 weeks or longer. For you, 2 weeks. For us, maybe longer. So question, will that interval getting that assay back shorten? Is that inevitable? It's going to take a week or less? And right now, is the cell-based assay only available at Mayo, or are the other labs also doing cell-based assays?
Those are very good questions. So first, is the turnaround time going to get better? I think it will get better, especially when more labs are starting to offer it. So then it can, if every single assay goes to Mayo, then, there's going to be a bottleneck. But as more groups are doing it, I think it'll help. In terms of the assay itself, so you just have to be careful on what you look at. For aquaporin 4, unfortunately, there are ELISAs out there. There's other kinds of assays out there. So you just want to look at it, because a false positive can be almost as detrimental or more detrimental than a false negative. I've seen a lot of patients who have just fibromyalgia who are on huge amounts of immunosuppression, and they're not getting better because, they don't have NMO. So then are other groups, other labs offering it? For MOG, for 2 years, it was just Mayo, but now other groups are offering MOG assays. They do use a cell-based assay, both AirUp and Quest. It's slightly not quite as good because they use a non-live cell-based assay instead of the live cell-based assay, but still much better than ELISA. So I would trust their labs if that's what's going to be quicker. Yes?
If you give steroids and they get worse, how does that change your differential? Which things come before?
Yeah, so the question is, if you give steroids and they actually get worse, does that change your differential? So that pretty rarely happens, fortunately. I would say if they're getting worse, there's 2 possibilities. One is it was already, essentially they could be an aquaporin 4 patient that was already destined to drop to very severe vision loss, and we're just kind of hitting them with steroids and it's a runaway train already, and we're not doing enough. And obviously, if we know they're aquaporin 4 positive, we're going to add on plasma exchange afterwards. The other question, the other possibility is it something that's not steroid responsive dependent and could potentially even worsen? And so that would be things like a fungal infection that potentially worsen things. That'd be on your differential. It's interesting. We're always worried about doing IV steroids for infectious etiologies, but for things like zoster or maybe even syphilis, I don't think IV steroids probably worsen things. But like fungus, it would. But usually they're going to have sinus disease and other things like that. Yes?
A couple of questions. Given that the pathology of the anti-MOG disease is so similar to type 2
I know.
pathology in MS, were you surprised that the MS medications didn't work?
Yeah, I think, it's obviously MS, it's more similar to pattern 2. I'd say that's the closest analogy to it, but there are some differences there too. And then I think a lot of those MS patients were probably more atypical cases. They're not your classic MS. So, maybe those were the patients that weren't responding. So maybe that might explain things. And then the pathology is a little bit different too.
Perhaps more on the anecdotal level, given that type 2 involves complement.
Yes.
Ectolism targets complement. Have you heard of anyone using ectolism in otherwise refractory anti-MOG?
That's a very good question. Are people using ectolism for MOG? Unfortunately, so the other 2 trials actually had some seronegative NMO in the study. But ectolism had no seronegative NMO. It made it a more pure study, but also doesn't help us here. It's hard to know. We haven't been doing it. Typically, if they've got really severe relapsing disease, we've been going to IVIG, and that's been kind of controlling it. But it's certainly a thought, and I'm sure there will be case reports out there soon showing that it's effective or not effective. I think both will be helpful. But the actual clinical trial didn't help us, whereas the other ones, the inebilizumab, the satralizumab, interesting, the seronegative MOGs, actually, they didn't respond that well, as you probably know, to those medications, so those aren't going to be that helpful for MOG, most likely. Yes?
On NMO, you give steroids, and then you quickly go to flex if you're not getting worse.
Right.
And for chronic things, if you could get rituximab, would you like to use that, or do you prefer, if you can get rituximab, or do you prefer something else?
So for aquaporin 4 NMO, is our first line still rituximab now that we've got these newer agents? It actually typically is still rituximab. It's been around a long time. It does work. It's every 6 months, whereas eculizumab is every 2 weeks, and it's 400 or 500,000 a year. So we actually are going to rituximab as first line still, even though there's no randomized trial proving it's better than placebo. We know it's better than placebo. We know it works. So we've been going to rituximab first line, and if they break through really severe, we know we've got something to catch it.
It's sometimes hard to get rituximab with
I know.
various insurances.
Mm-hmm.
If you can't get rituximab, do you do a mycophenolate or azathioprine?
Yeah, those are the other 2 that we'll try. But yeah, ideally rituximab.
And on MOG, you blast them with steroids.
Yep.
If they stay stable, you don't give them something, but if they kind of return, you go back to I can't pronounce ectolisumab or something like that.
For MOG, if they
Anti-MOG.
for anti-MOG, if they start recurring, or first line is still typically rituximab or azathioprine. If they break through that, we've actually been going to IVIG. We haven't gone to eculizumab with that yet, just because we actually don't really know. We think it probably acts through complement, but we're not sure.
If you use IgG long-term, you want to be using it long-term for a long time.
The IVIG, that's a good question. In children, that's when we use IVIG a lot more, is in children. And oftentimes we'll do it for a year and then actually taper them off. Yeah, in children we do, because children actually, interestingly, I didn't get a chance to talk about this. Oftentimes it may be more monophasic, whereas in adults it's probably 50% or more relapse, and in children it's probably only a third relapse. Great.
Thank you.
Great, thank you everyone.